Hello, good afternoon, everybody, and hope you had a good lunch. Welcome to this session on complex cases. Do you have the view from the microscope? Is it clear? So this patient,
We can see it, yeah.
yeah, this patient had lens surgery Phaco with foldable IOL, maybe like about 15 years ago. Patient has pseudo exfoliation, and he came with a dislocated lens. The lens is in the anterior to mid vitreous. I think you can see that. So can you see the lens? So that's the lens. It's a dead back syndrome, which you get in pseudo exfoliation, and we are seeing more of these cases. And you can see this is an old type of lens. It's the SI40 or maybe the Alcon. I think it's like the Alcon three-piece lens, which was popular. Now this is acrylic lens. You can see the square edge. You can see the full 6 mm optic. So this was done about 15 years ago. So now I'm going to show you the modified 4-flange technique of doing this procedure. So first you need to put in an infusion line. So it's very important that all anterior segment surgeons know how to make a pars plana port.
Let me ask Dr. Ronald, how would you manage this case, Ronald?
I would refer it to Sri Ganesh.
So just go in a little obliquely and then
Yeah, in all seriousness,
down
you
there.
need to retrieve this.
So you can see once you put the infusion port, the lens actually kind of floats up a little. It's almost in the mid-vitreous cavity, and that's the trocar. Okay, can you fix it?
Challenges sometimes in reaching.
So you can see that it has come up a little. So first we put the infusion on to pressurize the eye, and it kind of floats up the lens a little. Now I'm going to do a tunnel. To explant this lens, and I'm planning to put a SF IOL PMMA lens. So this is basically I'm reflecting the conjunctiva. Conjunctiva and the tenons. Interestingly, this patient has a large blue zone, the zone between the anatomical and surgical limbus. So I'm just cauterizing the blood vessels here.
What kind of block you are given this patient, or are you doing it at the topical?
So you can see this is the, so I make a, now I have to make a scleral tunnel. So there's a little bit of ooze, but then that's okay. A slight frown shaped 6 mm incision, and okay, I think I have entered visco. Okay. Visco. extension code. Forceps. Yeah, I'm using the MST forceps now. I grab the lens. Dialer. I get a grip on it. Very important to get a grip on it. And then, okay, bring it into the antechamber and then, okay. Just slide it out. And then there is vitreous, so you need to do a vitrectomy.
Sri, would you consider having
Side port.
retained that lens and fixing that lens by Yamane?
You can
or
do it
something?
with by a Yamane technique, but again, I see the haptics were not visible. So I'm infusion on ಆಗಿದೆಯಾ? Infusion on. So if you do not know whether the haptics are intact or not intact, then that makes a difference. If the haptics are intact, then you can just do a vitrectomy and then, okay, that's the vitreous. So I'm doing the vitreous anterior vitrectomy to remove the vitreous. You can also use the pars plana route, but you need to clear all the vitreous. See, if your haptics are intact, you can do that. You can do a Yamane, you can just remove the bag, eat it up with the vitrector, and then just do the fixation. I have done that, iris depositor or cannula. But if you're not sure, if you don't see the haptics, and if you're not sure one of the haptics may be broken, and then if that's the situation, then you can't really do a Yamane. So this is the vitreous. You can just sweep the vitreous strands. So just by sweeping from the side port, you can kind of do a vitrectomy and release all the vitreous strands in the wound.
What are the settings on the vitrector, Dr. Sri?
Vitrector settings in it. So this is, bring it closer. It's at 5000 cut rate, 50 IOP, vacuum is 700 and flow is 26. I'm using the Centurion machine. I just need to release the strands there. So once you clear all the vitreous from the antechamber and the mid-vitreous cavity, then you have a round pupil. You can also stain with triamcinolone, but then
You didn't take the measurements from the limbus. Yeah. That will be about. Ganesh, are you talking? We can't hear you. We can't hear you, Ganesh, if you're talking. Audio. We can't hear them. Ronald, would you like to tell the anatomy of the limbus and where is he entering into the, where has he made the ports?
It looks like he's made them about 2 millimeters from the limbus. As we know, the pars plana is about 3.5 there, but I do know a lot of people do use to enter at 2 millimeters from the limbus.
hello, can you hear me?
Hi, Sri, we can
Yeah,
hear you now.
Okay. So I've done the exact thing on the other side, and this is the PMMA lens now, which I'm going to use for the fixation. Okay. So you need, the flange has to be on the bottom of the lens. So I'm turning the lens here. Okay. And this is on the temporal side. So I just pass it through the eyelet there. After passing it through the eyelet, I use a thread burner. You get these even on Amazon. So you can just use this to create the flange, and you also ensure that the flange is thick enough and it holds so it does not go through the eyelet.
What lens is this, Sri?
This is a PMMA scleral fixated IOL with eyelets from Orolab. And just ensure that, okay, that your other proline suture is free and not entangled. So that is something you need to be careful. Yes, that it should not cross. So just put this in, and then of course you can just tighten this a little. Then I'm going to take this proline, put it from top.
Does it matter if you come top to bottom or bottom to top?
You have to come from the top to the bottom. That is very important. and then you just flange it. So once the flange is adequate, you can just check that the flange is adequate, and then you can just insert the lens. Dialer kodu.
Sweet, do these flanges ever break off from the suture if they're under tension when you fix the lens?
No, usually not. So this is, you can just dial it in, and what has happened here? Yes, it is. See, you can see that the flange has broken. Innೊಂದು lens ಇದೆಯಾ? Okay, but it doesn't really matter, but because the edge of the haptic is, I think, broken there, and it has got snagged in this. I think okay. I need, see, what has happened is, can you see that there is a double entry there? So, can you see that there's a premature entry there, and then it has gone in there? So what I can do is, I can just, either I have to redo the whole thing, or I can just cut the tissue there. See, scissor kodu. Because sclera is quite thin, I'll just go in and then retract ಮಾಡ್ತೀಯ? Okay, now that is done. Dialer kodu. Now it will get free. That's why it was getting snagged. Okay. This is again, this should have come on top. So that's the problem there. So what I'll have to do is, I'll have to redo this, which I will do, because otherwise it's going to rotate, and then you can see what has happened. This has to be over the haptic. Let me see if I can just fix it.
Can you redo the flange?
Yeah, I can redo the flange. I can redo the flange. So I'll just redo the flange. It's scissor kodappa. So you can just cut the flange, then
can you stop? Do you think the stopping the infusion will help you, the viscoelastic, if you do it?
no, that's okay. That's okay. Okay, now this is separate. Then I take it from top, and then Now it should be okay. I flange it again. Saline on the cornea. So now it is okay. You can see that the direction is okay, and then I insert it in. Centers well. Okay. So there's a little bit of, because the tunnel is not perfect, it is prolapsing, but anyway I have to suture it, because even if you make a tunnel and if you do a vitrectomy, then sometimes the tunnel does not hold. So cut it for about 3 millimeters away, and then you can flange it. The same thing is repeated on the opposite side. Zero madapa. Microscope zero mada. So the same thing again. Pull it tight, hold it. Cut the suture and flange it. But mop maಡು. Okay. Mop maಡು. Because there is, yeah. Mop maಡು. Okay, the flange is not perfect, but anyways, we will. Okay. So now you bury the flange, you just pull on the conjunctiva and bury the flange and push it down. So it's under the conjunctiva, you can see that it slides on the conjunctiva. Same thing on the other side. Bury the flange. You can see that the lens is very well centered now. Infusion kadme mada. Reduce the infusion. Okay. So I just take the iris depositor and then deposit the iris there. Okay, then I'm going to put a couple of sutures now. Light ag infusion haku. Kadme mada. Infusion off. Visco kodu. Problem is, again, the tunnel here, the sclera was thin, and if you excessively cauterize it, then you can have this problem. Anyway, I'm going to just put in some viscoelastic, which I can remove later.
Sri, with this 4-flange technique, do you think your lenses center better or are less twisted compared to a Yamane?
Yes, the advantage with this is the centration is better. You don't get any tilt. Sometimes in Yamane you get a decentration, you get a tilt, and you get pupillary capture. Here you don't have those problems, though you need a bigger incision for the PMMA lens. But I have a lens, a foldable lens, and with that you can actually do the whole surgery through a clear corneal incision of 2.8 mm, but we are still waiting for the approval. So once it's approved, then may take a couple of months more. I was hoping it will get approved by Phaco festival so I can do a demo, but unfortunately it's taking more time than anticipated.
Dr. Bianchi, if this case presents to you, how do you manage in your country?
Well, maybe I levitate with the vitrectomy by paraplana, the lens, depend of the case. And I used to put artisan retropupillar because it's
Iris retrofixation is another technique, but again, I've done quite a few iris retrofixations, but there is again a chance of pupillary distortion, and basically with this technique you can't make out whether the lens is a PC-IOL in the bag or scleral fixated. And you don't have to do scleral flaps, you don't have to use glue, so it's less complicated.
Shri, with your experience, you mark the diameter 180 degrees apart.
Yeah, 180 degrees apart, about 1.7 millimeters from the limbus.
But for a beginner, probably would recommend a marker.
Yeah, you can mark it. You can even use the digital marker, but I've done quite a few of these. Been doing it for quite some number of years, and then I'm able to kind of approximately know the position. Okay. Infusion on model
Are
now.
you going to confirm the presence of vitreous strands by injecting or infusing triamcinolone at this stage?
Pardon, I can't hear you.
The use of triamcinolone, would
Yes.
you like to?
Yes, you can use diluted triamcinolone or put triamcinolone about 0.1 mm so that it stains the vitreous, and then you will have a better idea whether there's any vitreous in the anterior chamber. But here basically because I use the sweep technique where I kind of sweep in from the side port and I'm able to release all the vitreous. I'm able to visualize the vitreous strands. So just washed out most of the viscoelastic in the anterior chamber. Hydration. So you can see that there is no vitreous in the anterior chamber. This patient has some thinning of the cornea and sclera also, which is a little abnormal. So maybe that's the reason why there was like a premature entry. The depth was a little deeper and we got a
How did you calculate the IOL power in this patient? The lens is sitting little far behind when compared to the capsular bag.
it's almost the same. I mean, these are cases which are difficult, and most of the cases you are within one diopter. Vitrectomy ಕೊಡು ಸ್ವಲ್ಪ. There you can see that there's a little vitreous strand there. So I'm just going to kind of infusion on idea. So I'm going to remove the infusion now. And that's the end of the procedure. I'll just form the AC, kind of cauterize AC.
Dr. Bianchi, when you want to levitate the lens up there, would you do it yourself or would you take the help of a?
Sometimes I need the help, the third hands. Yes.
AC. Could I not? The problem is when you loosen the speculum, suddenly this patient
That's excellent, Dr. Shri. Marvelous demonstration.
Thank you very much.
Tough case. And you did a good job, very good job,
Thank
excellent
you.
job.
We had a little bit of a problem because of the, I think the premature entry and the scleral bridge which was there. But I think we were able to overcome that. And you can see now it is fine. The eye is soft because of the vitrectomy. So once you remove the speculum, again you need to check that the chamber is formed well. So just hydrate the side ports a little more. You see? So I just inject subconjunctival there, and that's the end of the procedure. And this is a technique which is actually easy to perform, but you need to get the orientation of the sutures properly.
Dr. Shri, did you consider doing this technique from the temporal side, which would have made the tunnel formation easier?
You can do it from the temporal side also. I've done sometimes clear cornea also, extend it and suture the clear cornea, and you put in the ports at 6 o'clock and 12 o'clock.
Right. Would it have any advantage because when you were creating the tunnel superiorly, the instruments were touching the speculum, so you had to reorientate the direction.
Yeah, you can even do it temporally. You can even do a temporal scleral tunnel or a clear cornea. If you do a clear cornea 6 mm, then you need to suture it anyway. But even a scleral tunnel, if you have done a vitrectomy, then it's better to suture it, because sometimes you saw that the sclera was actually quite compliant and soft, so it has a tendency to collapse.
Dr. Ganesh, I mean, it's a wonderful surgery as usual. I think for beginners who want to try this technique, a little more easier way to do is we pass the suture before on the table itself. You pass the suture through the eyelets. You make the flange on both sides, and then start the surgery. So then what happens is, what you need to do is you just take the needle and then feed the suture.
No, but how will you flange it on both sides? Because you have the suture in the needle.
Right, sir. You need to cut it. So you need to cut it just like how you feed it into it. Like a straight needle on both sides. You take 2 needles, straight needles. Then you flange on one side.
No, this is a hollow needle. This is a hollow needle through which I have threaded the proline.
Right, sir.
So it's a railroad technique.
No, how we used to do that suture, right, sir? The scleral fixation lens.
See, the proline suture, the 6 proline, you don't get straight needles. It's
Yeah,
on curved needles. On curved needles. So again, that's an issue. If you have a straight needle, then probably you can pass it directly.
Right, sir.
Yeah.
So before, how we used to do the same scleral fixation, we used to use the needle.
Yeah, the straight needle is available with 9-proline and 10-proline.
Correct.
But 9-proline and 10-proline, again, proline degrades over a period of time, and then after about 5 to 10 years, you can have a dislocation again. But with the 6-proline, it's much thicker, so it does not cut so easily. It doesn't degrade so easily, and then it remains for a longer time. But the 6-proline, you don't get a straight needle. You get a small bent needle which you can't pass through the sclera. So that's why we just cut it into pieces, preload it in a 27 gauge needle and then pass it through.
Yeah, no, absolutely, sir. I think that when we prepare before, sometimes, it becomes a little more easier, but fantastic surgery, sir.
Thank you. Thank you.
Thank you, sir.